Ladies and gentlemen, good morning. Good morning on this sunny day, the 1st of March, 2024. We always save the best for last. And that is significant in our webinar series also. This is the last in our webinar series for the Weight Loss Challenge 2024. And our topic, obesity under the scalpel. And this topic has been selected with a lot of thought. We have done several seminars prior to this. We have had our seminars in diet, all relevant to obesity, exercise, medicine. And in our last webinar, we discovered that about 40 to 70% of genetics, 40 to 70% of obesity was genetically correlated. So we've had a series of webinars that lead up to this webinar on bariatric surgery. Bariatric surgery may have started way back in the 50s. And my understanding is that annually, globally, more than 500,000 procedures of bariatric surgery take place. And there's a good reason for this. This is perhaps one of the most successful methods of weight loss. And the decision to undertake bariatric surgery is not taken lightly. You need special considerations, BMI of above 40 perhaps, comorbidities and so on and so forth. And when I looked at those considerations and I compared it to our population of 18,000 plus registered participants in this weight loss challenge, I discovered to my amazement that we had more than 1,000 eligible individuals in our registered group of weight loss challenge participants who would benefit from this procedure. Keep in mind, of course, that obesity is a complex, multifactorial situation. It's not simply a matter of diet and exercise and medication. Genetics comes into it. It's a complex issue. However, to speak about this today is our consultant bariatric surgery from RAC Hospital, but speaking to us from Oman. Ladies and gentlemen, my great pleasure to introduce our speaker today, our faculty, Dr. Ladha El Zaqui. Dr. Ladha is a highly qualified and vastly experienced surgeon in general laparoscopic and bariatric surgery. He completed his MD and FRCS from Brussels in Belgium. He has more than 35 years. He has also got his FRCS from the same location. And he is a member of the several institutions, the Federation for Surgery for Obesity and Metabolic Disorders, that's IFSO, the International College of Surgeons, ICS, and the International Association of Endoscopic Surgeons, IAES, and is a founder member of the Gulf Obesity and Metabolic Surgery Society. We are certainly privileged. He has worked it would not be incorrect for me to say that he has worked in several locations in the world over the last 35 years, and that includes the UAE, Oman, Bahrain, France, and Belgium. And he has vast experience in the topic in which he will be speaking today. Beyond being a surgeon, Dr. Zaqui, as I see it, is also a linguist. I notice amongst his several languages, of course, there is English and Arabic, there is French, there is Dutch, there is Hindi, and Swahili. That's a lot of languages. Ladies and gentlemen, my great pleasure to hand you over to Dr. Ladha El Zaqui.
Sir, you have to mute yourself.
Oh, sorry. Thank you so much, Professor, for your kind words. So I will just try to put the screen on. And can you all see it?
Yes, doc. Perfect.
Perfect. Can you hear me?
Yes, doc.
Okay, perfect. Thank you. So first of all, welcome everybody. I understand you are 18,000 plus in this webinar probably today. Many of you have been going through these 3 months of hard exercise and weight loss programs. And congratulations for coming to today. Some of you may have succeeded very well, and that is a fantastic thing. Some of you may need some other help, and that's why we bariatric surgeons are present here today. We are here to help you out. We are here to find solutions for you in your weight loss journey. We will come through it on the implications of it in the topic that we are going to have just now. Ça marche pas. Wait. Sorry. So obesity affects, I mean, so many things which I've been saying, you all know it since ever. It affects more than 30% of the population in the world, and probably more in our part of the world, which is around 40% in the UAE. As you can see in this screen, the countries in red are the countries which are the danger country, and we are in the danger zone. Not uncommon to see this type of patients in our practice. All these ladies with their bias will hide their weight because black helps a lot. But what is most hurting is our children. When we see them eating the wrong way, and that is extremely hurting. Today, there's 39 million children under the age of 5 who are obese, which is little more than half the population of the GCC. And 340 million children in the world between the age of 5 and 19 who are obese, which is 6 times the population of the entire GCC. This is a dramatic issue. Then we've tried everything. We've done diets, we've done exercises, we have done injections, we have done whatever we could, and we still have weight problems, and we still have weight complications. Then we can help you. And especially this last 20 years or more, laparoscopy has really helped us do this surgery in a minimally invasive way. Surgery for bariatric is not something which is new. It's something which has been done since many, many years. So it was first invented, I love history, because history teaches a lot of things and helps us correct our mistakes of today. The first one was done in 1950, was a jejunal ileal bypass, which didn't succeed. The patient died from complication of malabsorption. But then later on, people came with ideas. Mason in 1966 saw that actually, while doing a total gastrectomy for patients for cancer of the stomach, they lose weight. So maybe we can bypass the stomach and that could help lose weight. So when we see that so Mason also invented another type of technique, which was very popular in the 1990s when I was studying, which was the vertical banded gastroplasty, which was done open surgery. And then in 94, the first bypass came over under laparoscopy, and that was the start of this era. But just before that, the gastric band, the Phobie band, was put in Belgium by Guy Bernard Cardier. I should talk about Belgium once in a while because that's my country. And we put the first laparoscopy gastric banding, which was in 1992. That became just it flared up in Europe. People were putting thousands of them in the 1990s. And that came up to an end after a certain while. So let's go to the procedures on its own. The gastric balloon, something which people talk about a lot, but it's not something new. So what happens? We give a tablet or a pill which people swallow, or we can put it by endoscopy, which is a scope through the mouth, and we push a balloon inside the stomach, which is inflated with saline most of the time, can insert and mix with air, and that fills up the stomach and gives you a sensation of satiety. But the first balloon dose of 1985, you see, is not something which we just invented, but there were complications and it was discontinued. It became very popular since the approval from FDA in 2015. At that time, people started to put balloons left, right, and center. But balloon has its own complications, which are on everyday nausea, reflux, ulceration of the stomach due to this foreign body. When the balloon melts, it can go and obstruct your bowel. It can create perforations. I've had patients I had needed to operate in emergency because the balloon had created a perforation of the stomach. A patient was in peritonitis. Pancreatitis can happen also in certain cases. But once the balloon is out, then what happens? If we haven't changed our habits or we haven't learned from having putting it, the weight comes back. And a few months after, we have them coming back, say, put me another balloon and then another balloon or do me something else. That's where this something else comes. But I don't see the balloon as a step to get to surgery. I think that a step to get to surgery is much faster than the balloon. So we have here multiple types of surgeries. We can see that it is something which is just every time something new has come up. The first one, the gastric band, popular in the 1990s. Till the late years, still some people do put it in the world, but most of us have really stopped doing it. A band is placed around the upper part of the stomach, which is attached to a port, and you can inject water inside the port, so inside this part of the stomach, which inflates the band there and makes it tighter so you eat less. A fantastic tool, but it has its own complications. Dilatation of the pouch, the migration of the band. So we won't go to the complications of the band because it's not anymore a popular surgery. Then in 1999, somebody invented the laparoscopic gastric sleeve. So the sleeve was a part of a procedure which is a most complex procedure before, which is the duodenal switch. And somebody thought that if we just make a stomach out of it, it should just work, a small stomach. So in 1999, the gastric sleeve started to become popular. It became popular very much in the Middle East. Actually, it's the place where it started to become so popular. In Europe and in US, and still today's day, the gastric bypass is still probably the surgery which is performed the most and which has the best results in the world. But the gastric sleeve is a simple procedure, simple by its accomplishment, but not simpler by its complication. So basically, a tube is inserted in the mouth and we cut the stomach on size of the tube. The tube varies from teams, from French 32 to French 40. I use a French 36, so I stay in the middle, and we create a pouch of the stomach. We'll go through the complications of the different type of surgeries together because they're almost all the same. The gastric bypass, which is probably the best surgery today in US, which is the most acknowledged surgery in US and in Europe. So we create a small pouch with the upper part of the stomach. We cut the bowel. Now discussions are on the length of this, which is called the biliary limb. We cut it at around 75 centimeters. Some people lengthen it now. And we take, which we call an alimentary limb, which is the Roux-en-Y limb, which is connected to the stomach. So the food comes from the mouth through the esophagus into this tube and goes down. And in the middle, and after a meter and a half, the bile from the bile from the liver, the juices from the pancreas, the juices from the rest of the stomach come and mix with the food and start the digestion. So from there onwards, the food is absorbed into the bowel. So we have bypassed about 150 and 75 centimeters of bowel, which are used just as tubings. Scopinaro had invented a surgery which is called the duodenal switch, which is a very complex surgery and which very much morbidity is post-op. I don't like that surgery, especially in the Middle East, where patients don't do their follow-ups properly. They come, they do the surgery and then disappear. They come maybe for the first or the second post-op visit, but then they disappear. This one has a lot of metabolic malabsorption syndrome, and we need to be careful when we do it. So basically, we just pull a 2.5 meters tube from the end of the bowel, and we cut the small bowel there and then reconnect it at about 100 centimeter. This is so the bile will bring the fluids here, and the food will be absorbed on a very small portion of the bowel. Then, we are very inventive, we surgeons. So we said, well, that's complicated. Let's do more simple. So we invented the SADI, which is the single anastomosis duodenal switch. So there, basically, we take the distal part of the small bowel. So we take about 3 meters of the small bowel. We cut the stomach after performing a sleeve, and we just cut it after the pylorus, which is just the first step after the stomach in the entrance of the duodenum, and we reconnect it. So what happens? So the food goes from the esophagus into this small pouch, so you eat less, and then it goes into this part of the bowel. The bowel moves only one way, so the food will be pushed one way. It doesn't go backwards. So the bile will come, the bile will come from that part which is left, do the whole loop of the small bowel which is left which is around 3 to 4 meters approximately, and then come in contact with the food and digest the food from here onwards. This is also a very malabsorptive surgery, which needs to be taken with care and which needs to be used with care for patients today. So, surgeries is good. There is also one surgery, I should have mentioned it, is the one anastomosis gastric bypass, which we just do a SADI, but with a longer bowel, with a sort of a SADI with a longer bowel. We just bypass 2 meters of the small bowel. So pre-op, intra-op, and post-op, what do we do? That gives us the type of selection to do. So the patient criteria, preparing the patient, the anesthetic evaluation, and how we reduce the risk. These are the important steps of the preoperative steps. So how do we select our patients? Today, a BMI above 35 can go through a bariatric surgery, or a BMI above 30 with one major complications, diabetes, cardiovascular disease, sleep apnea, etc., severe arthritis. People have made significant efforts to lose weight. They are in a good mental health, and they are able to follow instructions and to show commitment to what we tell them to do. The contraindication are patients who are very unstable. These are basically the contraindications for all surgery or anesthesia. When there is a severe pulmonary disease, which doesn't allow us to do a general anesthesia, where there is portal hypertension, which creates major veins inside the stomach and the bowel, and which can bleed drastically when we cut them. When there is mental health issues and people, that they're psychotic and they will not be able to follow what you ask them to follow. So the pre and post-op diet need to be discussed. They are the very important component. You have to have an informed consent. the mental preparation, because these are huge changes in the lifestyle. And if there are any comorbidities, ask the specialist to see them. So we have to educate the patient to allow them to consent to the surgery. We have to evaluate them properly. We have to encourage behavioral modification. So we can do that by many steps, by informal sessions, by seeing them in the OPD, by evaluation by all the members of the care team, by an examination, by discussion over time. It's not a decision we take on the first consultations. Unfortunately, it happens a lot today in this world that we see the people travel, go and do the surgery and come back, and all that in 48 hours. So patients should be empowered. They should be a partner in their health management. It's not we only the healthcare providers. We should be taking that. Patients are also partners in their life. They are the master of their health. If they don't understand that, they will never progress. So they have to understand that we are there as a care team to establish the expectation, to take time, to discuss, to answer the questions. But they have to take the decisions to do the surgery and to do what is taken, what is needed to make it successful. They have to understand the risk that they are taking. The common risk, the risk for the health, the risk which are impertinent to the anesthesia, the risk of DVT, the risk of everything, and the balance of the risk should be discussed. But we need to understand all the health risks associated with obesity. I'm sure through all these webinars, you have understood that obesity creates a lot of issues with your health: cardiac issues, heart issues, cancer issues, infertility issues, arthritis, social issues, everything comes there, psychological issues. Those are important things to put into the balance. Sometimes it is better to take a risk on a surgery than to let the things just evaluate longly. There are alternatives. You have to understand them. You have to understand that common type of surgery. They have to understand all the risks and the benefits of each of them. Am I okay with time?
Yes, doc, absolutely. There is no problem. You
Okay.
can have 20 more minutes.
Okay. So the impact of weight loss is something which will work on the emotional health and the relationship. Just tell you a little story of mine. One of my ladies, I did a gastric sleeve for her, and she lost weight drastically. She looked a very beautiful lady. So the guy started to turn over her and look at her when she was walking with her husband, and the husband became extremely jealous. But that impacted their couple life. But those things do happen. So we have to manage expectations. Don't give them unrealistic view. You will lose everything in one day. Or your blood pressure is going to be sorted out as soon as you do the surgery. It takes time. It does happen, but it takes time. We will sort out most of your diabetes problem, probably 90% of them. We'll sort out most of your blood pressure issues, but it takes time. It doesn't happen overnight. It's not, I've done the surgery, my diabetes is gone. We should emphasize to the goals of the surgery that he should understand where he's going to be. So it is part of a lifelong weight management program. It's not just we do the surgery and that is it. We should change our habits. We should know that if we don't do what is right for our health in the future, the weight is going to come back. There are preparations. Discounting some medications like aspirin has to be stopped 7 days. There are certain herbal remedies which have to be stopped for a month before. Stop smoking, because smoking increases the risk of infection risk, of ulcers, of leak, of pulmonary issues due to post-op. If they lose weight before the surgery and they start exercising regularly before the surgery, it helps a lot during the anesthesia. It helps them recover faster post-op. The anesthesia preparation. There are so many health conditions which needs to be known before the surgery. They may be having some cardiac issues which are not there. They may be having some sleep apnea, which needs to be dealt with, which needs to be treated probably before. So they have to understand that the anesthesia for obesity is a complex anesthesia. Sleep apnea, very common. People snore in the night. We don't know why. My husband stops breathing for a minute in the night. I have to shake him to wake him up. That's sleep apnea. But that is very, very common in obese patients. But that can create problems post-op, especially if it is a very severe sleep apnea. And they may need to be having their machines before the surgery to help them breathe after the surgery. We have to have the adequate equipment. Not any operating room can accept any operating patient. The tables should be adequate. They have to go to a weight which is above 300 in certain cases. We have to have security where the table stays on place and doesn't move while we are doing the surgery. Beds in the hospital should be the size which may be required for the patient. The chairs, the tables, everything. The care team. The care team should be ready to do the surgery in a good manner. We have to choose the right candidates, we have to prepare them for behavioral changes, and we have to set realistic expectations. So, the mechanics of the surgery, the anesthesia administration, and how do we reduce the risk? So, we have to make sure that we have chosen the right patient. We are going to have all the equipments which are right in the operative room, that we have backup in case of breaking up, that we have the people who are there to help you do the surgery are the right people that day, and the patient is positioned properly. Because so many patients have injuries of the nerves after the surgery. Their arms hurt for months, or their legs pull and it is sleepy for many, many years, for many, many months, or maybe years after the surgery, because the position was not very right on the table. Anesthesia has to know how to do the anesthetist. I'm not going to go and teach them how to do it and how they should intubate a patient which is an obese patient, and they have to have so it needs a privileging to give anesthesia for obese patients. The position for the anesthetist, for us as surgeons, we have to make sure the patient is placed properly so we don't have any injuries of the nerve, because we are going to deal with them. We have to have the port which are placed in the right place, because if they are badly placed, it makes our surgery more difficult. We have to expose. I've had one case in my life where the liver was so big that I just couldn't lift it. I stopped the surgery. I told the lady I cannot do the surgery because it is too risky. I can't see your stomach to cut it properly. We have to have angled scopes which allow us to go and see very deep, especially in the upper part of the stomach next to the spleen. And we have longer instruments if they're longer patients or fatter patients. We have to prevent so many type of complications during the procedure to make sure that we do it on the proper way. Infection, check the bleeding, make sure that our instruments to stop the bleeding is right, the staple line breakdown. We have cut the NG tube with the staplers and we haven't seen it happening. And when the anesthetist tries to pull it out, he pulls the stomach away. Retaining, we can forget a gauze inside if we use sometimes a gauze because it was bleeding in the time, because we don't use it usually. We have to take precautions for DVT, which is deep thrombose of the legs. Veins which are sitting there stagnant for an hour or 2 hours of surgery can create clots and they can move to the lungs. So we have to put stat stockings, we have to put them a pump eventually, we have to inspect the staple line for a leak, we have to do a test during the surgery, put a blue test or an air leak test, make sure that instruments are on the vision so we don't perforate the small bowel while not seeing it, make sure we have an obstructed something, or we put the wrong size of the band, but for a gastric band, for instance, there are internal hernias which happens, we'll talk about them later on, or incisional hernias, make sure we close all those gaps. The post-op management, PACU, room, and then discharge, and how we reduce the risk all along. So in recovery room, make sure that the patient is followed up properly. He's only discharged from there once he is fully awake, the pain is controlled, and is breathing properly. We have to monitor in there. If the patient, if he's diabetic, we check his sugar. If he's very obese patient, his BMI is above 50, he probably needs to pass a night into ICU or into HDU. The post-op risk, so a good care, a good team, they know how to work, communicate properly. That means that if you are not there in the night, the doctor who is there should know what has happened during the surgery. People should know if there was anything happening or any complication which happened during the surgery. So we need to be careful, and we have to monitor the patient properly. Make sure he's pain-free and try to reduce the narcotics, because the narcotics create respiratory difficulties. So post-op, we can do a gastrographin swallow test or a blue swallow test if you have a tube drain next to it. So we give a dye to check if the anastomosis are correct. In the gastric bypass, there's not only one, there are two anastomosis which we need to check, because the second one can leak too. So that's why the one anastomosis, there's only one anastomosis to check, which is a surgery which I start liking more. So that is the leak test. That is the first thing. In the sleeve, the same thing. We can give them gastrographin or clinical. We can usually know it. So then we start feeding them. So they start with water. I tell them take the lid of the bottle, and one lid at a time, and then we go to clear liquids, and they stay on liquids, on clear liquids for a week, on heavier liquids for the second week, and then on blended foods for a month. Because it takes about 6 weeks for the stomach to become solid. I've had a guy which story comes back to me. I saw him, I did his sleeve. I saw him after a week. He was doing fantastically well. That was a Thursday evening. That was just a week after the surgery. I was so happy that he was doing so well. He calls me early Saturday morning. He wasn't well. He had a leak because on Friday, that idiot went to eat a burger and biryani. He couldn't resist them, and biryani on a Friday evening a week after the surgery. So you should know that those things are dangerous, and they do happen. It is not something that it doesn't happen. So the leak is the most dreaded post-op complication, and undetected leaks can create severe infection and peritonitis and lead to death. So the caregiver should look out for the complication, for the indicators. First is a heart rate which is higher than 110. Call the doctor. Tell him that is not happening, something is not right. Fever. The patient is having difficulties in breathing, or the white cells counts, but that is little later on when we check the blood test. So the nurse should call the doctor once there is a heart rate which is high and it is a leak until proven otherwise. So then we go and do a test. We'll come back to a picture of the leak afterwards. The other thing is obstruction. The anastomosis is too tight. It could be an obstruction up there. It is that the food doesn't go through. It could be an obstruction down there. So this is a down obstruction which happened because there was too tight. I spoke about the hernias. This is the hernia on the abdominal wall where the bowel got. This is a sleeve. You remove the stomach. You didn't close the hole because that hole is larger. So you close that hole. So then the bowel doesn't go inside. Then you have more complicated obstructions between the small bowels, which you have pulled up, which you need to close those gaps. They have very complicated names like Peterson defects and others, mesentery defects, but those are names for us to enjoy our life. DVT, major complications. We don't see it much because we are very careful. They get injections of anticoagulants before and after the surgery, and we continue them eventually at home. They have stockings to wear so that they increase, and the patients are encouraged to walk straight away after the surgery. As soon as they're fully awake, we start making them walk and they go to the bathroom. We can have bleed, can happen on the liver, on the injury of the spleen, which is just very close to the stomach below the liver. We can injure it and it can bleed later on. The vessels between the spleen and the stomach are very short ones. They are shared with the stomach, and we have to free them when we do a gastric sleeve. We can bleed lower part, and that is not detectable, not straight away. because the upper part, if it bleeds, they will vomit blood, or we can do an endoscopy and find it. But what about the lower part? The scopes are not long enough to go till 1.5 meters or 2 meters to check that part. So that is something which can happen also, and it may need re-exploration. This is a picture of a leak after a sleeve, which is very, very small leak, but it is there, and that creates infection. So how do we deal with it? Many types of dealing with that. Talking about sleeve, because sleeve is the most common surgery in the Middle East today, we have to go into a gastric lavage. So we go back by laparoscopy and we wash it if the patient is septic, and then we can put in a stent, which is a sort of a metal or a plastic coated tube, which is put inside the stomach, which covers the hole and allows the food to go through. So we leave it for about 4 to 6 weeks, depend on the type, and then it's removed by endoscopy. So that is one way of dealing with leaks. Other ways for a sleeve, we change it into a bypass. We patch it with a jejunum, because sometimes we put a T-tube inside the hole and pull it out. So all are different types of management which are possible. So just a topic on the leak. The leak on the sleeves are probably more common because the pressure on the pylorus, which is the outer part of the stomach, are quite high. So the food is pushed backwards, because in our area, when we have sorry, there's a thing which popped up here, which I
Sir, you can click the red dot on left top,
that one
left hand top.
is that one
No, your screen is out.
is gone, right?
Yeah.
Sorry. Yeah, can you see it?
Yeah. Now it's clear.
Oh, sorry. So the pressure of the pylorus is sometimes high, which pushes the food backwards and creates reflux and may create more area of leaks. We don't have that hyper pressure in the bypass because there is no pylorus there. It's just obstruction of the stoma which is there. So it is probably less leaky. Now, what certain surgeons like me do, which I'm a coward surgeon. I've had leaks and I don't like dealing with them because they're complicated to leak. So to deal with. So on the staple line, I don't only staple, I oversew the entire staple line. I bury the entire staple line. And when I do a bypass, I bury all the staple lines, and the anastomosis between the stomach and the small bowel, I do it hand sewn in 2 layers, which gives me, maybe I'm wrong, but gives me the the idea that I'm being more protective to the patient, and probably that helps me sleep better, but it has reduced drastically my risk. So instead of a surgery taking maybe 45 minutes to do a gastric sleeve and run away, it takes me maybe an hour and a half. But then as I tell to the patient, that doesn't matter. You are sleeping anyway. I'm working, so I'm the one working more, and your family worries a little bit more for longer time, but you go safer home. So there we are. We come to the end of this topic. I hope I've covered everything you needed to know. I'm open for all your questions, and there we go. Doctor?
Dr. Ladha.
Yes, Professor.
That was fabulous.
Thank
It
you.
was a story. It was you so with such simplicity and clarity. You gave us the you gave us the history of bariatric surgery, and then you took us on a journey of the actual event. Just a minute. I'm sorry, you had a screen pop up and I have a screen that just popped up to tell me that I need to start my video. So I am doing that. Now I can see myself on screen, but I'm going to repeat myself. Sir, that was said with such simplicity and such comprehensiveness. You gave us the historical background of the entire surgical process of bariatric surgery, on the one hand. And then on the other hand, you actually showed us diagrammatic representations of the different forms of surgery that you did. And then you expressed your own concerns, which made us so comfortable about your safety protocols and your care for the patient. And I loved your stories. I loved your stories. I absolutely loved your stories, two of which I remember straight away. When the lady on whom you did surgery, she looked so beautiful that she began to get the attention of a larger audience. Now, which lady in the world would not want that? That is fabulous. That's a good story. And I am amazed at the other story, which you mentioned, where post-surgery, this gentleman whom you had conducted the surgical procedure on actually had biryani and hamburgers. Whoa, whoa, that was a complication that you couldn't have expected. Doc, that was absolutely brilliant, and I am not going to keep you for 1 second between your audience. I am sure that they have several questions, but I want to thank you profoundly and personally. I mean, knowledge is a great thing, and to impart the knowledge the way you did was a profound experience for me. Thank you so much, sir. I now leave my audience available to ask you questions. Dr. Wilku.
Yes, sir. First of all, thank you, Professor Dr. Ladha, for a very informative session. Like we said, this is our fourth weight loss challenge. And every time we have webinars, we have different topics. Even we have bariatric surgery also. But the way you put on, many participants, every time when we face, they are very much confused that they read in the Google that even after doing the bariatric surgery, there are a lot of complications and they want to avoid that. So that is one part of this. 1 second. Doctor, yeah, Ladha, you are there. Yeah, I was just wondering whether you skipped or okay, one. So that was the reason this topic, your session was very much interesting and it was full informative. Now I will take few questions which we expect every time because we come across you being a practitioner, you might be experiencing more. But in the challenge for the participation of weight loss, we come across many questions. Like one of the question, Harsehaj has asked, in the bypass surgery, will it cause improper digestion and gastritis as the gastric juices will continue to produce acids and drain directly into the food pipe? We are talking about bypassing the stomach.
Yes, so it may produce to a certain extent, but usually gastritis is not a major complication which we have. Malabsorption can happen. So, but if you follow what we tell you to do, so you have to take multivitamins. This is the first thing which you need to take, and you have to take it from the start. So first is in gummies for the first few weeks, and then after that is just a multivitamin which is complete for I'd like to say for at least 4 or 5 years, because people don't follow that, but at least for a longer time until you absorb better. So our system is very well done. The small bowel is a fantastic tool. When it is shortened on absorption of food, we have what we call velocities inside, which are small waves of small bowel mucosa, which will increase their length after a few months. It will increase the length to absorb whatever the body needs. And we will see on the distal 1 meter of the small bowel how much those velocities will increase in length and size to increase the surface of absorptions of many micronutrients and macronutrients. So our system is is a fantastic computer which finds solutions for itself to increase our health. But that's not enough. We need still to be careful on what we eat. So I like to say to the patients, when you start eating properly, or when you start eating after the liquids phase, focus on proteins. That's the first thing you put. Focus on veg and fruits, because that's where you'll get your calcium, your iron, your vitamins, your everything which is required for your body to survive. These are the two main things. The rice, the bread, the pastas, the potatoes, the sweets, the mithais and all that stuff, that's not necessary. So that's, you should take some. Carbohydrates are necessary to give you the energy to sustain your day, but in a smaller portion and not the first thing that you take. You take your multivitamins. You will need protein supplements in at least the first few months of after the surgery, until you really start eating properly your foods, so your muscle stays fit. Exercise, important step of part of your journey. So first month, walking every day 20 minutes. That's a must. From the second month, you start exercising your entire body. I want you to exercise the entire body. The the not only walking. You take a YouTube, you take an exercise at home, do 20 minutes of a full body exercise. It's enough, because moving the body, moving the muscles maintains the muscles, and you burn the fat. So what we want is to burn the fat and maintain the muscles. Maintaining the muscles will help you have less sagging skin also, because it will really help you that way. So yeah, so there we go. So will you have malabsorption in the future? If you take care of yourself, no.
True. So means post-operative is as much important as the pre-op.
Yes,
So
and the follow-ups are important.
follow-ups are also very important. Yeah. Then that's the reason second person has asked, Sarfraj has asked, who actually benefits with the bariatric surgery? Is it for all obese people or for specific people?
So all obese people who have tried to do something for their weight and do not want to be obese in the future. What you need to understand, Safaraz, is that today I have a BMI above 35. What should I expect in 10 years of having this BMI on my health? In the next 10 years, you may develop diabetes, you may develop blood pressure, you may have a heart attack, your risk for cancer is 3 times more than the risk of the normal population. So your risks are higher. Then it's for you to manage your benefit risk. I'm good with what I am and I'm happy with what I am. I'm continuing my life like that. That's perfect. That's your choice. You are the master of your health, but you have to know where you're going with it. So if you do a diet and you lose weight and you get better in shape, that's better for you. You see,
True.
I'll share you one more story. I don't know if I should, but
Yeah.
I will. I did a
Yeah, sure,
bypass.
sure.
I did a bypass one day. It was a family of three. I remember that the lady was 60 years old. She was on 7 injections of insulin. And
Oh,
so she did a bypass. And I think 3 months after, she was off insulin completely. So she sent me her younger brother and her husband. So the younger brother had sleep apnea, terrible sleep apnea. He would fall on his computer at work. So I did his gastric bypass. And a month later, he calls me. He said, "Doctor, I need to tell you something." So I said, so I started to be scared. I said, "What's happening?" The poor guy, what's going wrong? He said, "Doctor, I just want to tell you, I had the best sex of my life yesterday." And he was married in so many years. He said, "I couldn't focus on it before. Now with my weight loss, I feel so good. I don't sleep all the time. I'm healthier." You see? And that's what life is about. That can be achieved by weight loss, by doing a diet, by doing a good diet. That's perfect for me. I don't need to operate on you. You have to understand that. But if you need it, we are there.
yeah, true. That's only comes if you're not able to lose the weight. Yeah, Dr. Madhurima has asked, she's concerned about her brother. Her brother is grossly obese, has BMI is above 45, and has ulcerative colitis. In bariatric surgery, is bariatric surgery safe? And what type of procedure you would suggest for him?
So for ulcerative colitis, it is a disease which is just limited to the colon. So it is not into the small bowel. So that is a fantastic thing. He needs to be controlled by ulcerative colitis on a proper way. And I'm sure that losing weight will help him control also his ulcerative colitis. We don't know how or why, I don't know at least how, but it does happen. So I've had patients with Crohn's disease. So with Crohn's disease, I usually prefer doing a gastric sleeve because I don't touch the small bowel then, because we don't know. Crohn's can goes into the small bowel and may impact that one. But an ulcerative colitis, basically anything he can do. I would suggest a gastric bypass or a gastric sleeve. The gastric sleeve is the easiest one and is the simplest one. We don't touch the bowel and we don't change anything in the absorption system.
Great, great. Surprises again, he has more confusion. Is bariatric surgery safe for health? Because you have even, I was going through the presentation when you are talking. So you have given all the good points also and negative points also if the patient is not doing a proper follow. So people
Exactly.
are concerned about that. So surprises asked, is bariatric surgery safe for health? Does this surgery have any side effects on the body?
It does. All the surgeries have a side effect. So the first are the complication perioperative and postoperative, which is about 1 to 5%, which is the leak, the bleeding, etc. Then on the long run is malabsorption, that you because you're not taking your tablets. It's stricture of the pouch, which can happen on a gastric bypass, which may need to be dilated afterwards. I've talked about it briefly at the moment. You can have internal hernias, so this can happen in your lifetime. So they are dangerous. You could have the most important thing is people who do not take their multivitamins. I've had people who come suddenly after a year or 6 months of the surgery in a wheelchair to my office. I said, "What's happened?" "He can't walk, doctor." Because he didn't take his multivitamin, so he was deficit in vitamin B complex. His nerve was not functioning. You give them vitamin B IV, and suddenly they start walking. You see, because they don't follow up. They come back after a long time. One of the most annoying complications on gastric sleeve is gastric reflux. That does happen in sleeves, and that's where we are taking a step back on gastric sleeve surgeries today, because gastric sleeve does create about 30% in patients after the surgery, severe reflux, which may need a corrective surgery after that. Because the severe reflux leads to Barrett esophagitis and then may lead to cancer of the esophagus. It's not very high in proportion, not very high in percentage, but it is a concern today. And as we have been doing left, right, and center gastric sleeve, especially in the Middle East, that's why the other countries in the world have taken a step back, and we are re-evaluating it to put it as the best surgery in the Middle East today. So yes,
Okay, great.
you have some complications.
Right. I just received one question in the WhatsApp. You mentioned about the complications of gastric balloon therapy. Are the symptoms long lasting and permanent, or it is for a shorter time?
Well, it goes away when the balloon is gone. That
Ah,
time is finished. But some people really suffer for many, many months when the balloon is there. Because some of the balloons, we put them for a year, and you have nausea and vomiting for a year. But
oh,
the time after a few weeks, it just subsides, it gets much less.
okay. And sir, another question is that people generally Google and they read you. Most of the people, those who go for a bariatric surgery, they regain the weight after a year or 2 years like that. So is it true, or means how much percentage people get away?
So regain of weight is common. How many percentage? I don't have the figures today. I can't tell you, but we do see a lot of them which come back after a few years. Now, why they come back?
Yeah.
Because they don't change their habits. So as I tell my patients when they come to me, I said, listen, you have a surgery, you are going to do a surgery. It is not, it is use the time after your surgery to change completely your habits on eating and of the way you do. So they do it. They do it. They eat the right foods for a year and a half, for 2 years. Then they start eating cake every day. Then they start having ice creams every day. Then they start having sweet drinks every day. Then they come back on Coke and on dew. I don't know why they love dew. They drink dew all the time. And that is pure sugar. And then the weight comes back. Then they come say, doctor, now the weight is gone. Weight is back. Do me something else. And then that's where we are, you see. Because if you
True.
commit, that's where I say you need to commit to changes.
True. Unless you commit yourself, nothing is going to help you.
Exactly.
I think so. Yeah, I have finished because most of the questions which I received separately also covered. Okay. Okay, 1 second. Okay, one person has just messaged me saying just what you said. Uh, After surgery, many people regain their weight and they come again for do something else. So, is it whether they are thinking like it's a quick fix for weight management so that their weight has been cut out, the fat has been cut out, and now they are free to do anything? So, it should not be like a quick fix.
It shouldn't be like that, right? But it is like that in this part. People just come and do, and if you say no, they travel and they go and do somewhere else.
True, true, true,
Because
true.
someone else will do it, right?
Right, right, right. I think I have covered everything. 1 second, I will just have a look. Yeah. From my side, everything is being covered. Professor, over to you.
Yes, thank you, Doc W. Doc W, while you asked the question as to what is the weight regain post surgery, I recall reading just last night while preparing for this webinar. I recall reading, and I made a little note over here which says that there are over 500,000 bariatric surgeries, about 600,000 odd bariatric surgeries done globally. And the weight gain or loss after 10 years on an average is that the body reduction of weight is at least 50% over 10 years, which means that the weight loss is retained for a longer period of time in the majority of the population. That's one thought. My second thought was the series of questions asked on complication. Now, you really have a choice between your weight and the problems that accompany it. The solution, which in this instance could be bariatric surgery if that is the route selected by your doctors. As far as the complications are concerned, I believe that we as patients have as much responsibility to ourselves to follow all the instruction given to us by our medical professionals. So my statement over here is that let us look at the benefits first and then manage the responsibilities. I don't quite know whether I put that right, but that's my statement. Friends, I want to once more thank Dr. Ladha El Zaqui for his excellent presentation. And the excellence comes in simplicity. He has spoken in a way that all of us, even mostly non-medical professionals, have understood this so well. I would like to thank my audience. And I would like to even inform my audience that I would even like to inform my audience that at the end of this session, we have the weight loss challenge is going to end up with a weight loss clinic for the rest of the year. And bariatric surgery is certainly going to be one of the options that we offer for the great benefit of our overweight population. I would like to thank my audience as I have, and I would like to thank Dr. Wilku for those questions and for managing this. I'd like to thank Arabian Wellness and the support team. And I believe that for a moment we had put up the closing function, which will be on the 2nd and 3rd of March, which is tomorrow and the day after. Friends, tomorrow, the 2nd of March, and the day after, on the 3rd of March, we will be having the final weighing in. And on the 6th of March, we will declare our results. And you will all be rewarded, in a manner of speaking, for the hard work that you have put in. You will be rewarded. You will reward yourself by the weight that you have lost. And let us not forget the lovely stories that Dr. Zaqui has told us about the benefits of having lost that weight. And with that, ladies and gentlemen, goodbye and good day. Thank you so much.